All right, so we're going to talk about asthma now. So the epidemiology of asthma, it's characterized by variable and recurring symptoms. Airflow obstruction and bronchial hyperresponsiveness and inflammation is the key underlying factor. Remember that asthma is reversible. It is reversible. An estimated 18.7 million Americans that are adults have asthma. So most people think of asthma as a disease of children, but adults have it as well. And a lot of older adults that have asthma also have COPD. So there's a lot of overlapping between the two. Again, remember that it's reversible and that there's diffuse airway inflammation. So bronchoconstriction, it occurs due to allergens or irritants. It's hyperresponsive, the bronchioles are hyperresponsive, and the person will develop airway edema that is worse as asthma severity worsens. There can be remodeling in the lungs, and this remodeling can progress, like it can become irreversible. That's very severe asthma. They've had it for a very, very long time. And it's not something that you just automatically associate with asthma. So for the most part, asthma is reversible. COPD is definitely not reversible. And asthma is like your immune system. It's your immune system like going haywire, basically. Some health promotion, disease prevention to think about with asthma is that smoking cessation. I can't say smoking cessation enough. Personal protective equipment, again, it's just like COPD. If they're exposed to certain things, it can cause an asthma attack. You would want to encourage the flu and pneumonia vaccination. You're going to teach the patient to recognize and avoid triggers. They could have triggers such as environmental changes when it's going from cold to hot or vice versa, the humidity. Like, just think about how the humidity makes you feel like you're suffocating. It's way worse for somebody with asthma. Air pollution, strong odors. People that have asthma can be set off by odors. So you want to make sure, like you personally, don't have perfumes or colognes on because it can cause a person to have an asthma attack. Certain medicines, seasonal stress, certain medicines like beta blockers, certain cholinergics can cause it. Certain chemicals can cause it. If a patient has a respiratory issue, like a viral respiratory infection, that can cause it. You want to teach them infection prevention. Hello, hand washing. Great way to prevent infections, like the number one way. And self-administer medicines. I can't talk about, you need to know how to use certain things, how to use inhalers, which I have links in my PowerPoint to, not links, but I have page numbers so that you can go reference how to do that, because they're very important for you to know. Regular exercise, it promotes ventilation, maintains cardiac health, and a person who might be susceptible to bronchospasm would need to be pre-medicated. And then you can also teach the asthmatic to use hot water because it will help get rid of dust mites. Certain risk factors, age is a risk factor because as the person gets older, they have a decreased pulmonary reserve. Older adults tend to be more susceptible to infection, and their beta-adrenergic receptors decrease in sensitivity, so they're less able to respond to agonists, which means their smooth muscle relaxes, and it results in bronchospasm. Smoking. Secondhand smoke. Allergens, like the environment, dust, chemical, and then GERD. Now, the relation between GERD and asthma is kind of fuzzy, but it does exist. I have some possible reasons as to why it occurs in my notes if anybody cares to read it. But the big takeaway is it's a risk factor. So manifestations of asthma. So diagnosis is based on history, physical examination, and spirometry. The most common findings are going to include dyspnea, chest tightness, anxiety, and stress. The patient with asthma can have mild intermittent, mild persistent, moderate persistent, or severe persistent. You can look on 125 in the ATI book that talks about the different types of those things. Like somebody that is mildly intermittent, they're just going to need their rescue inhaler once or twice a week. But somebody who's severely persistent is going to need a lot of medicine on a daily basis to help control their asthma symptoms. A side note about what everybody calls asthma or exercise-induced asthma. It's not really exercise-induced asthma. It's exercise-induced bronchospasms. Because the only kinds of asthma, there's 4 kinds: mild intermittent, mild persistent, moderate persistent, severe persistent. You didn't hear exercise-induced asthma in there. Just exercise induces bronchospasms of the lungs, which causes the client to have an asthma attack. And so basically what that person needs to do is they need to build up their pulmonary system in response to exercise. So they just need to exercise until that starts, and then they need to stop, and they need to exercise after it goes away and slowly build it up. Some other findings of asthma include coughing, wheezing, mucus production, accessory muscle use, prolonged exhalation, and they might also have a poor oxygen sat, especially if they're having an attack. And they could have a barrel chest, but that would be after having asthma for years. You want to obtain their history. So how long has this asthma, how long have they had asthma, how long have they had this particular attack of asthma, what caused it to occur, was there anything going on before this occurred, any recent changes to their medicine, have you done anything to relieve the asthma? Has your rescue inhaler relieved the asthma? Has the rescue inhaler not relieved the asthma but helped it a little bit? Is there anything else that you're taking that may have caused asthma to occur? Are there any self-care methods? And most importantly, with somebody who has had an asthma attack, you need to know if they've ever been intubated before. ATI doesn't talk about it, but if they've ever been intubated before, the likelihood that they're going to need to be intubated again is quite real. So if they've ever been intubated because of an asthma attack, it's an important thing to know because you need to know how quickly you need to act, basically. Laboratory and diagnostic tests. Just like in COPD, you're going to take ABGs to see if there's anything affecting the arterial system, basically. And you're going to look at sputum cultures, and that's just to rule out infection. For diagnostics, the pulmonary function tests are going to be your most accurate for diagnosing asthma. And again, the nurse does not do pulmonary function tests unless you're working in a pulmonary office and they want you to do that. But you need to know what the diagnosis, how they get diagnosed. So if a patient has a decrease in forced expiratory volume in the first second by 15 to 20%, that is common in asthmatics. They give them a bronchodilator, and if that increases by 12%, then that is diagnostic of asthmatics. And then the chest x-ray will just look at if there's been any changes in the pulmonary system, basically, in the lungs. Patient-centered care, positioning, positioning, positioning. High Fowlers, it helps promote and maximize ventilation of the lungs. Give them oxygen as prescribed. Going to monitor their cardiac rate and rhythm. Now, if they're not on telemetry, you need to, note their rate and rhythm when you do your assessment. But if they're on telemetry, that needs to be monitored on a every 30 minutes, like routinely. You don't take your eyes off your patients in intensive care pretty much. IV access, make sure you have it. Make sure you're calm, because if a person has an asthma attack and you are not calm, well, they're not going to be calm either. And you really only need one person to not be calm in this kind of situation. Cluster the care like you do with COPD, because guess what? Somebody that has asthma, they probably are going to get fatigued a lot quicker than somebody that doesn't have asthma. Encourage that the client knows to receive quick care for any type of respiratory infection, because unlike a person who doesn't have asthma that develops a cold, if you have asthma and you develop a cold, it can develop into something more serious a lot quicker. Encourage vaccinations and administer medicines as prescribed. I feel like I'm repeating myself on a lot of this, but please. Management goals: symptom control, maintenance of pulmonary function and activity, prevention of recurrent exacerbations, so know what sets off their asthma and help them to learn to prevent it, provision of optimal pharmacotherapy, and patient education. All right, this is basically an action plan. So if someone is an asthmatic, they are going to know to use their peak flow meter every single day so they can see where they are. So their peak flow meter is going to have, where's my mouse? It's going to have a red zone, a yellow zone, and a green zone. And what they do is they breathe into it to see where their levels are. If they're green, then they are good. Their medicine is working and they're not going to have any issues. If they blow into the yellow zone, it's like a red, green light, yellow light. They need to be cautious with what they do, and they should have a treatment plan for any actions that need to be taken. So they should have developed a treatment plan between themselves and their primary care provider. And then if they blow into the red, they need to stop everything and seek medical attention. So this next slide is what a peak flow meter basically looks like. So you see they have, it's again green, yellow, red, and they blow into it. If you go to page 364 in your Honan text on 11.9, it will tell you what the person needs to do and how to use a peak flow meter. Please know how to do that. All right, pharmacologic therapy. I'm not going to repeat what I said. I'm just going to add to what I said. Again, we have bronchodilators and anti-inflammatories, and then for asthma, we have combination therapy, which is a combination of bronchodilators and anti-inflammatories. So in asthma, they have long-acting beta-2 agonists, which are for prevention. But please understand that these LABAs, which is the short of long-acting beta-2 agonists, there is a black box on them. Because there has been studies that show that the LABAs alone used in asthmatics put them at an increased risk of cardiovascular death. So they need to be used concurrently with inhaled steroids. Then we have anti-inflammatories. Certain anti-inflammatories are more for asthma. Like I said previously with COPD, we have your leukotriene antagonists, which Singulair or Montelukast is the generic. Is an example of your mast cell stabilizers. An example of it is cromolyn, and then your monoclonal antibody. All right, and an example of your monoclonal antibodies is omalizumab. And yeah, I haven't given that much. All right, so omalizumab is one of the medicines that I haven't given much. But it can cause anaphylaxis. But refer to COPD for considerations in education. And in the combination agents, really what you need to know is that they would administer the bronchodilator first, so the anti-inflammatory medicine can be absorbed better. Respiratory failure is a complication for asthma, so please refer to COPD for that. And then status asthmaticus is a life-threatening complication, and it's an episode of airway obstruction. Not responsive to common treatment. The presentation, we have extreme wheezing, labored breathing, accessory muscle use, and distended neck veins. If it's not treated efficiently, it can lead to cardiac or respiratory arrest. The actions that the nurse would want to do is prepare for emergency intubation. If somebody is going into status asthmaticus and they are in the hospital setting, you would call a rapid, just like you would for respiratory failure. Make sure there's IV access and prepare to administer IV epi, IV fluids, oxygen, bronchodilators, and steroids. And remember that a quiet chest is an ominous sign. Your chest, you should always hear something. Always. So if you don't hear anything, that is bad. And there's the references. I hope you've enjoyed this video. And I hope you've enjoyed Thanksgiving break. And I will see you next time. Thank you. Bye.